Welcome everyone to the Vaccine Town Hall for All. My name's Ace Burpee and I'll be running things tonight in terms of asking questions. We have an amazing panel. Big thank you to Doctors Manitoba for hosting these town halls. I hosted the youth and parents and caregiver one last night. Some incredible questions and some really, really good info. So thank you to Doctors Manitoba and thank you for joining us this evening, and to everyone who had a question, a concern, wanted clarification. Hopefully we get to as many of your questions this evening as possible. There is always more information at manitobavaccine.ca that is run by Doctors Manitoba. It's independent of the government COVID-19 website, manitobavaccine.ca. If we don't get to something you wanted to hear tonight, that information is constantly being updated. Before we begin, I would just like to say on behalf of the physicians participating tonight and Doctors Manitoba, we acknowledge that medical services across Manitoba are located on the original lands of First Nations and Inuit peoples and on the homeland of the Métis Nation. We respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit and Métis peoples in the spirit of reconciliation. As for our panel, I will introduce you, and if you can say a bit about yourself. So pleased to have with us this evening, Dr. Osler. Dr. Osler, thank you.
Thanks, Ace, and hi, everyone. I'm Dr. Gigi Osler. I'm an ENT surgeon here in Winnipeg. I've been in practice for 23 years, an assistant professor at the University of Manitoba, and a past president of the Canadian Medical Association.
We appreciate your time. And Dr. Potter, thank you for your time this evening.
Thank you, Ace. Hi, my name is Jen Potter. I'm a family doctor. I work at a teaching clinic and with the University of Manitoba for family medicine. And I do some research in vaccine communication.
Right on. Well, great to have you, and thank you again. Dr. Singer, thank you for sharing the evening with us.
Hi, I'm also a family doctor. I'm an associate professor at the University of Manitoba, and I also have a research portfolio. I'm the Director of Research and Quality Improvement for the Department of Family Medicine.
Nice to have you. Dr. Heendeniya, thank you for your time this evening.
Thanks, Ace. I'm Dr. Heendeniya, as you heard, or Dr. H by most of my patients call me. I'm one of the infectious diseases and internal medicine doctors through University of Manitoba and the 3 major hospitals in Winnipeg. So I've seen all of COVID so far.
All right. Well, thanks for taking I know you're all extremely busy, and this is a great service you're providing. We appreciate it very much, including Dr. Poliquin. Thank you.
Great. Thanks for the intro, and thank you everybody for being here tonight. My name is Vanessa Poliquin, and I am an obstetrician gynecologist at Women's Hospital Health Sciences. I've been practicing since 2016, and I'm also an associate professor in the Department of Obs and Gyne here at U of M. And I am co-chair of the Infectious Diseases Committee of the Society of Obstetricians and Gynecologists of Canada. So thanks for having me tonight.
We appreciate your time. And rounding out our panel this evening is Dr. Kalicinsky. Thank you for your time.
Hello, everyone, and thank you for joining us. I'm an adult clinical allergist and immunologist. So I assess and manage patients with allergies and also certain immunodeficiencies. I am a faculty person at the University of Manitoba. I've been in practice for 22 years.
Well, we appreciate you all sharing tonight with us. We'll get to the questions again. Thank you for all your questions. We're going to cover a lot tonight. This one actually, that Dr. Osler, will start with you because there's some a bit of a moving answer on part 2, but let's start with just how effective are these new vaccines at preventing COVID infections? Is COVID even serious enough to need a vaccine?
Thanks, Ace. And, for whoever submitted the question, I want to say thank you. And when I talk to people about vaccines, there are some who have questions and who are hesitant. And I saw a recent survey that said about 21% of Canadians still have questions, aren't sure, or are waiting. And so that's really why we're here tonight, to talk about the vaccines and hopefully move people from vaccine hesitancy to having information and some vaccine confidence. And when we look at the vaccines, I want folks to know three things. So first of all, for vaccine effectiveness, they usually have to come in at about 50% efficacy to be approved. And when you look at the clinical trials, and I'll talk about the three vaccines that are available in Manitoba, so Pfizer, Moderna, and AstraZeneca, in the clinical trials that are done before vaccines are approved, for Pfizer, it had about a 95% effectiveness, for Moderna, about 94% effectiveness, and AstraZeneca, which everybody poo-poos, in the North American, South American trials for AstraZeneca, it was found to be about 79% effective. So you can see just from those numbers alone how much more effective they were in the trials compared to most other vaccines. So they passed the threshold that would be required. Then when you look at real world data, real world effectiveness, that's where you see in real people, in countries, in Canada, the effectiveness of the vaccines, especially with the 2 doses. And the latest study that I've seen has come out just about a week ago from England. So Public Health England reported on their real world data when they would have had the original strain and some of the variants going around, especially that Delta variant. And what they found was that if you had 2 doses of the vaccine, and they had Pfizer and they had AstraZeneca, if you had 2 doses of the vaccine, it was over 90% effective in keeping you out of hospital if you got COVID-19. And so, that's, I think, both trial data and real world data that I hope will help people to understand that the vaccines work both in the studies and in the real world.
So we'll stay with you, Dr. Osler, and this answer, so this was submitted yesterday, we received this question. The answer might be a bit different now, but if the vaccines are so effective, then why can't people gather indoors, or why do the fully vaccinated, or why are they required to wear masks, things like that? Now that answer is changing a little bit as we move forward, but speak to that if you can.
You're absolutely right. And if you listen to the news conference today, Manitoba is starting to reopen. And what we're going to see over the next few weeks to months is this sort of rolling reopening. And as cases of COVID-19 go down, as hospitalizations go down, as more people get vaccinated, and especially with 2 doses, we are going to see more of Manitoba reopen up. So more people indoors, more things opening up. And so, Ace, you're absolutely right. It is a bit of a moving target. And I, for one, am really happy to see our numbers come down, our vaccine rates go up, and Manitoba start to reopen up.
We'll go to Dr. Singer for this next one. Does anyone keep track of how many people get COVID-19 after being fully vaccinated?
Yeah, absolutely. So the answer to this is sort of mirrors a little bit what Dr. Osler was saying in terms of those real world effectiveness studies. And this is actually some of the kind of research that I do in my research world, which is using data from administrative sources, from electronic medical records and things like that. So this is absolutely something we track both here in Manitoba and of course internationally. So we do have really good numbers on this, and that's how we're able to put those numbers together and produce a study like Dr. Osler was saying, where we can see in the real world in England or elsewhere how many people have infection. So the Manitoba data, which some of it was actually just released to the public today, I understand, is about of the people who are getting the new infections. So when you hear those numbers, the case numbers each day, it looks like it's about 1 in 1,000 who are fully immunized. Those are the people who are in that case count that you hear about, daily or so in the press. And a very small number of those people, of those fully vaccinated people, are actually finding themselves in the hospital. It's something, I think the number that was released today was 235. 235 people that were fully vaccinated ended up in hospital, which is a really small number when you consider we've had thousands and thousands of people in Manitoba alone in hospital. And of those, 3 of them were admitted to the ICU. So a really small number when we have so many people in ICU, you know, over 50, 60, 70, so many so that they're getting sent out of the province. And 8 people who died were actually vaccinated. 7 of those 8 were over 70. And what my colleagues who work in the ICU have been telling me is those people are often, unfortunately, people who had other conditions, right? So we know when you get vaccinated, if you're already ill or you're on immunosuppressive drugs or you have things like major kidney disease, you may not actually mount the kind of response that protects you. And so one of the reasons to get vaccinated actually is to protect people, those small number of people who have major conditions that even when they're vaccinated aren't really fully protected. And so we do keep track of these things. And that's exactly why, that's the kind of research that we're doing to make sure that the vaccines work and to be able to understand these kind of things in really great detail.
We'll go to Dr. Heendeniya for the next question. So if I ask you, how do we know these vaccines are safe? When someone asks that question, a lot of people they're not really, a lot of them are not just thinking about the next day or two. They're thinking more so of the long-term effects of these vaccines. So if you can speak to that in terms of actual safety, both at the time you receive it and moving forward.
Right. So thanks, Ace. We know the vaccines are safe from a trial perspective because even though the trials happen very quickly over the year, there has never been a medical trial that took this many patients into account and with worldwide collaboration. So we know the safety is there. The other thing that we are comfortable with the long-term effects here is these are not new technologies. I don't know if people know, there's been other mRNA vaccines that's under trial as we speak and has been in the past. So with that previous vaccinology knowledge and the fact that we have the safety data from the trial, we are, as physicians, we are comfortable saying this is a safe vaccine. The other thing is, there's always the option to wait for long-term data, but when you're in a pandemic, we had to think about the safety of all of us as well. So that's another reason to not wait for the long-term data. So I would say benefit of the vaccine definitely far, far outweighs any potential small risk of long-term safety issues.
Appreciate that. So this is big. I hadn't heard talk of this until a few days ago. I'll go to you, Dr. Kalicinsky. More than one person has written in saying they've heard that many people have died from taking the vaccine, and they have cited the vaccine adverse event reporting system. What is that reporting system? Is this true? If you can speak to that.
Okay, well, the VAERS, vaccine reporting system, is a specific one for the U.S. And people send in reports to the system. Now, I think we should focus on the one in Canada specifically, because we do have one. It's called the Canadian Adverse Events Following Immunization Surveillance System. This one is available for people to view. Accessible, fully accessible. I think you just have to, Google this system, or just even Googling Public Health Agency of Canada COVID vaccine reactions, and you will find it. It's updated weekly. I was on it an hour ago, and it lists reactions according to gender, according to age, and also probably most importantly for everyone, according to what the type of side effect or adverse event was, and also severity. So physicians that are told about any kind of adverse event of vaccine, even if it may not be related, are to submit a specific form. It goes to, in Manitoba, it goes to Public Health Manitoba, and that's reviewed, and then it gets forwarded to Public Health Agency of Canada, which works with Health Canada to put on this site. So if you look at that site, you find that the the vast majority of adverse events reported are local reactions. So even local reactions get reported. By local reactions, it means the reaction at the injection site. The adverse events that are listed as severe are definitely the absolute minority. And also, if you look at the numbers, even within Canada, the huge number of vaccines administered, and you take that into context with what you see on that site, you can see how very small those kind of serious adverse events are. And I'll just quote Dr. Josh Reimer from March, indicating that we know more about vaccine safety than we do about any other medical intervention in the world. So I think that also says a lot.
Awesome. Dr. Singer, you are up for the next one. It's sort of there's a few different angles to it, but if someone missed last night, this is all about vaccines and children. So that 12 to 17 demo. But how can these vaccines be safe for children? Aren't kids basically immune to COVID-19? And then more than one person has sent in something hearing about the World Health Organization advising you not to give vaccines to children. So a lot there, Dr. Singer.
Yeah, so the World Health Organization, what they say is we don't have the data yet, right? So these studies are underway. The World Health Organization is not recommending that kids shouldn't get vaccinated. They're saying we need to do this in the trials first, and when we have the information, then we can make a decision. So that's a slightly different point. So I understand that there's a bit of nuance there, and I understand where that can be confusing. And a lot of what's happened during the pandemic has been a little bit confusing, right? Because we've been watching science play out in real time. People when you're doing scientific studies, people make a hypothesis. You take your best, what you think the answer is going to be, and then you test that in settings. That's what trials do. You say, we think this is going to work, and you test it out. And so there's lots of things that we know really well, and there's things that we don't completely know. And what we know from vaccines in general is we know that they have a very high safety profile in children. We don't see issues in general in vaccines in children. What we know about the COVID vaccines is that they appear to be very, very safe in adults. So we don't see any safety signals that make us think there's any particular reasons why they wouldn't be safe in children. And we think that they're probably going to be effective in children, in part because they're so effective in adults. Now, the thing about children in terms of infectivity, in terms of how likely it is that a child is going to get infected, is that children after puberty appear to get infected about the same ways as older people. The difference is they tend not to have as many other health conditions. And so we've seen this very dramatic trend that older people seem to be affected by this virus a lot worse and are much more likely to get sick and or die. But sort of the adolescence age do seem to be able to get COVID, although, and thankfully, rarely don't seem to be severely impacted. In the kids under puberty, some of the studies we have from looking at schools and transmission in schools in those areas is the younger kids don't seem to be getting severe cases, but they do potentially serve as a source of some transmission. Probably smaller than the sort of young adults right now, what we've seen in Manitoba in the last few months has been the sort of 15 to 30-year-old range being sort of among the highest transmitters. So I think it's safe to say that what we know is that vaccines are generally very safe in children. We haven't had an example of a vaccine that, in the last 50 years that we wouldn't consider very safe to be used in children. We know that these vaccines, in the way that they're made, are likely to be very safe. But all that being said, we need to wait for some of these trials to finish up, and they're underway. And so there are children right now who have gotten the vaccine. We're looking, the scientists that have run those studies are looking to see how many of those kids do get infected, if there are any side effects, things like that. And when that data is ready, when that data is complete and all of the studies have wrapped up, those will lead to submissions for review by Health Canada and FDA and all of the international agencies that look at the study results. And I would predict, my prediction would be that these vaccines will be approved in children, and we will see children get vaccinations shortly, and I'll be lining up my kids to get vaccinated. But at the moment, we're saying we don't have all of the research yet at least in the under 12 range, because I know that I think it's Pfizer has wrapped up a study in 12 and over. But any of the panelists can correct me if I'm wrong. I'm pretty sure it's 12. The ages have been changing and the data has been changing so quickly that I don't want to be quoted on the exact age, but some of these studies are wrapping up and we'll see them, I think. I would hypothesize that probably later in the summer, early in the fall, we'll see some of these submissions come to our agencies and we'll know whether it's effective or not in kids. And I think they will likely be.
Questions about myocarditis. I'll throw it to you, Dr. Heendeniya. I'll give you a specific example. I'm worried about my adult son getting the vaccine. He is 22, and there's now a possibility that he will get myocarditis. Is this as bad as it sounds, Dr. H?
Thanks, Ace. I think this is a really important question, probably the most common question I get posed to in my clinic as well. So I'll talk a little bit about myocarditis and pericarditis. So what that word means is you have inflammation or a little bit of swelling in the actual heart muscle, which would be myocarditis, or the lining around the heart, pericarditis. These are uncommon things, but it's usually caused by multiple different reasons, including viruses, including COVID, autoimmune diseases, medications, and sometimes we never find a cause. More recently, especially as we started vaccinating younger populations, the data initially came from Israel that showed some cases that potentially could be linked to pericarditis following receiving the second dose of mRNA vaccine in the younger age group, 7 to 30 group there. And then we got some more data from the US, and we have very minimal data from Canada. So until now, we're not really exactly sure if the number of cases we are seeing is higher than the normal number of pericarditis cases we are seeing. But that said, we are at this point treating this as a potential side effect of the COVID-19 vaccine. So let's talk a little bit about numbers. The most recent number that came today from the US showed very, very rare side effect of pericarditis, 12.6 cases per million doses administered. So if you compare that to the pericarditis cases we have seen in COVID-19, there was one study that I can think of that I looked at younger adults that got COVID-19. The number was 2.3%. That means 1 in 50 young healthy adults who got COVID-19 developed pericarditis because of COVID-19. The other important thing is when you get COVID-19 from a lot of these other causes, there's a lot of lasting side effects. But luckily, almost all the pericarditis cases that's been linked to COVID-19, they tend to be self-resolving with some high dose things like aspirin and naproxen without any lasting side effects. So it's important to watch out for these side effects, but the risk of pericarditis should not stop you from getting the COVID-19 vaccine because the risk of COVID-19 is way higher.
So
Right on.
Can I clarify what you said there? That the cases that we're seeing with the vaccine are basically entirely treatable and no one's having any long-lasting effects from the vaccine-related myocarditis. But if you get a myocarditis or a pericarditis from COVID, from the infection, are you seeing, or you don't maybe look after children, but are we seeing long-term effects or severe, permanent damage in children?
Yeah, so I have not seen children, but I have seen one patient who had COVID-19, but actually looking at the data from viral pericarditis, which we see often, not necessarily COVID-19, they tend to have a very, very long recovery phase, ongoing exercise tolerance issues, ongoing shortness of breath, ongoing weakness in the heart. So that's what we need to avoid, right? One of the main reasons we promote vaccines in COVID-19, because we don't know what their long-term side effects are going to be, We're 15 months in, we still have patients with systemic.
Absolutely. I've had a few patients in my practice with viral myocarditis that suffered quite a bit. Absolutely.
I can't imagine why COVID-19 myocarditis would be very different from that.
Yeah.
Appreciate it. Dr. Poliquin, you will be up next. There's a few in here and there. There's a lot of concerns on the subject of taking the vaccine if you are pregnant or breastfeeding. Are there risks associated with that? Also, vaccines and miscarriages.
Yeah, well, they're all really important questions, Ace. And certainly being an expectant parent is hard enough in the pre-pandemic times. And this has been a really tough year for pregnant patients who have had some really tough decisions and tough moments with shifting information. And I really liked how Dr. Singer called this, this is real-time science evolving in front of us. And what we've learned over the past 18 months is really that pregnancy in and of itself is a risk factor for badness associated with COVID, including hospitalizations and ICU admissions. And so I think the first thing to take away if you're pregnant is that even though you are young and healthy, just by virtue of being pregnant, you have a higher risk of having to go to the hospital or the ICU or having a preterm birth. So there's a lot of benefit to consider vaccination. Then when it comes to the safety data that we have, I know if you are a pregnant patient, you hear, well, pregnant patients weren't included in the original randomized control trials. That can leave you with a little bit of a feeling of panic, and that's normal. But we're in a situation now about 7, 8, 9 months into a massive global rollout of the vaccines that we have available to us in Canada. And that has allowed for a huge amount of data to be accrued. It's allowed for hundreds of thousands of pregnant women across the world to be vaccinated, and their data is being used and analyzed to ensure that these vaccines are safe. So there is active surveillance that's going on from the drug companies and from independent bodies. For instance, in the States, we have the V-Safe registry, which has recently published probably the largest cohort of pregnant women who got the vaccine. And that was recently published in the New England Journal of Medicine. They published on 4,000 pregnant women who got their vaccine, and they compared them to to women who didn't get the vaccine, and they found that there was no increased risk of any pregnancy-related bad outcomes. So no increased risk of things like stillbirth or preterm birth or miscarriage. That's one of the things that I know people are anxious about. And on top of that, we have now access to high quality toxicology data for all the vaccines that are licensed in Canada, which means those are animal studies where they typically get a high dose of the vaccine, higher than you would usually use in a human, and that also is demonstrating no signal to harm for pregnancy. So at this point in time, while we still have the randomized control trials going on that are including pregnant women, we certainly have a large body of data that is highlighting no signal of harm to pregnancy or increased risk of miscarriages. When it comes to breastfeeding, again, the data continues to build, but we do have a recent study that came out that demonstrates that if you look at breast milk in 4 to 48 hours after vaccination, there is no vaccine in the breast milk. So we are not anticipating that the baby is getting exposure to any vaccine themselves.
And so what about, we'll stay with you, Dr. Poliquin, but what about questions around infertility? And so because we're still relatively new in terms of rolling out a vaccine globally, is there enough there to answer definitively that there is a relationship between vaccines and infertility?
So this has been another interesting phenomenon during COVID, that there are very intelligent questions coming out of the population, the non-medical population, that are excellent questions like, can this cause infertility? And what's really been interesting is just how rapid fire science is starting to answer these questions. So there were questions in social media about infertility. Researchers got to it. And in the past few weeks, we've gotten a number of great publications that have come out that demonstrate that men who get their vaccine compared to men who did not get their vaccine, there's no drop in their sperm parameters when they do a semen analysis. We have evidence now that women who have gotten their vaccine versus women who haven't gotten their vaccine, there's no difference in how their ovaries are functioning. And looking at IVF outcomes, so people who have infertility for other reasons that were already scheduled to go for IVF, their outcomes from their IVF are the same. So I really commend everybody who asks these questions. They're important questions to ask, and they are driving science, and science is providing us the answers we need, and they'll continue to build as time goes on.
The same kind of questions researchers are asking, obviously.
Dr. Kalicinsky, I'm going to ask you a very general question. There are specifics within it, but people have concerns and a bit of anxiety about the COVID-19 vaccine in relation to their allergies and them being at a higher risk for side effects or more severe side effects. And so concerns about allergies, Dr. Kalicinsky.
Thank you, Ace. And yeah, this is a question that I get asked multiple times a day from patients, just from the public and also by physicians. And, I do have to echo statements been made by previous panelists about the, the flux and the moving science. And of course, where this all sort of came up with allergies and the vaccines, of course, was the that first week in the UK when they had their rollout, and there were a couple of episodes within that first week of anaphylaxis, so a severe allergic reaction, and those individuals also had some food allergies. So of course, the UK at that time, for a few days, put things on hold for those that had food allergies or severe allergies until further assessment of those cases could be done, because you'd have to also look at each of the cases. And so things have really evolved since then, because now again, we've got many months of data, and the various allergy societies, the national allergy societies, including our Canadian Allergy Society, and I think all of us allergists in Canada, agree with this statement that after all these months of vaccination and of the billions of doses, and reviewing, like I mentioned before, the cases that are reported and they are then reviewed, it can be shown that individuals that have food allergies, drug allergies, venom stinging insect allergies, that means honeybee or wasp stinging allergies, and like I mentioned, environmental allergies, those individuals are not at increased risk of having an allergic reaction to the COVID vaccine, nor are they at increased risk of having any side effects greater than the overall population. So that's very reassuring. And there will be people that happen to have both allergies and reactions. There will be people that have absolutely no allergies and will have side effects, but the reassuring is that this is no greater in the allergic population compared to the general population. Now, if a person is concerned about their allergy history, whether or not they're followed by an allergist, or they have concerns because they, despite just what they're hearing, what I'm saying right now, they have concerns about a reaction they had to a medication or a reaction that they had to a previous vaccine, and need more information, then please talk to your primary care provider, and that primary care provider has access to allergists that are on call. We can be called up. Doesn't necessarily mean that there has to be a full consultation, and we can also give the explanation to the primary care provider. Plus also, if the primary care provider feels that more information is needed to be able to give an adequate risk assessment for any reactions for an individual who has had a reaction, say to a vaccine, or concerned about some of the vaccine components, then referrals can be sent to us. And we are definitely prioritizing these types of referrals. So no matter what people hear about wait lists, this is our priority currently.
So I said this off the top, and several of our doctors have doubled down on it, but the questions that we've received are amazing, and you're hopefully not only getting peace of mind, but you're also probably helping someone else. And I had never thought of this angle, and I'll stay with you, Dr. Kalicinsky, but what about someone who's taking medication or going through chemo? There are people who are concerned that perhaps the 2 doses aren't enough, and they're wondering about like having their antibodies checked to see if they are indeed receiving enough protection, which is an angle I didn't think of, and if you can speak to that, it's fascinating.
Okay, thank you, Ace. So the other hat that I wear, the clinical immunology part, is assessing and following patients that have some immunodeficiencies. So this is also a question that I'm getting that's posed to me on a daily basis. And that's correct. There's various reasons why people can be immunocompromised. So either because their immune system just doesn't work properly, or because it's secondary to medical conditions or medications that they're taking for other medical conditions. And for a lot of these questions, I also defer many of these individuals who are on specific medications like cancer chemotherapy or medications or immunosuppressants should also be speaking openly and asking these open questions to their specialists. But overall, it's correct. We don't know how well patients with people that are immunocompromised will respond to the vaccine. And there are, as we speak, there are studies within Canada, coast to coast, multi-center, that are working on answering those questions, both in the immunodeficiency ones, where their immune system just doesn't work because that's the way it is, and also those that are secondary to other conditions. That still means that it's still definitely recommended that they receive both vaccines. The vaccines will not give them COVID. I know that's a concern with some other types of vaccines that are called live vaccines. This is absolutely not. So it is safe in immunocompromised individuals. They're not at increased risk above everybody else in the population of having a side effect or an adverse event because of the vaccine. And I like to quote Dr. Fossey when I was looking through media in the past. When he was asked this question by hematologists, by blood specialists, he had said very short and simple answer: some protection is better than none. And, I think that sort of says it all. We will hope to have these answers about how well protected individuals are with various types of immunocompromised conditions, hopefully in the next 6 to 12 months.
Dr. Singer, anything to add on that?
What I would add is I think that's why everyone needs to get immunized, because there are people out there, whether they're on chemotherapy or immunosuppressive drugs for a particular condition, that they're not going to be fully protected. And so it's everyone else's job to help protect those folks, because if we can end the pandemic and we can stop the spread overall, then the people who, for whatever condition aren't going to get full effectiveness from the vaccine, they're going to be helped. So I think it's really important that collectively we keep that in mind, because there are a number of people I have patients in my own practice who have transplants, things like that, renal failure or kidney failure. And I know they're not fully protected, but they could get 100 doses of the vaccine. They still won't be fully protected. That's just the reality of their own bodies.
We still have so many questions to get to. Well, I'll try and pick up the pace here a bit. Dr. Singer, we'll stay with you. And this is, if you can speak to the vaccines being still experimental, their words, and wondering why the vaccines were approved under an emergency authorization. And is that different from regular approval?
Yeah, so I'm going to try to keep this really tight, because this is it's a really important question, and I've sat through whole lectures. There was a day worth of webinars that Health Canada gave trying to explain some of this. So basically, think about it in this way: when you're trying to do a study like getting a vaccine approved, there's a couple of typical bottlenecks, things that take a really long time. One of them is the early development, like the science behind it. And for COVID, the actual virus was sequenced within the first couple of weeks of it being identified. So we had the full genetic composition of the virus back in 2019, before the pandemic really had ever been an issue. When I was back as an undergrad, it took years to sequence the human genome. Remember, that was a big deal. We celebrated, the Human Genome Project. And now the COVID virus, the actual sequence is a lot shorter, but that happened in really, really short time because the technology has advanced in the last couple decades, right? Decade and a bit. And so that's one part that often is slow. And so there were people working on vaccines right from the beginning of when this virus struck the ground. The other thing that takes a really long time when you're trying to do a trial is actually enrolling people to be part of the trial. So I've done clinical trials before, I've participated with them, or randomized trials. It often takes a really long time to get people to agree to be part of a trial, the subjects, the patients. But everybody knew COVID-19 was a big thing. And when some of the companies said, oh, we've got a vaccine candidate, people lined up. It was record time that some of the trials were able to enroll 60, 70,000 people across the world. So that's the other thing that happened really quickly in terms of the studies. So to know that the vaccine worked and that it was safe. The other thing that happened was, because the pandemic was raging, Health Canada and the Europeans, the Americans, they all said, we're going to take a rolling submission. So that was part of this emergency authorization. So rather than waiting for all of the trials to wrap up, they accepted the information sort of on a weekly or bi-weekly basis, so that when the people who do approvals, because they got to review every single part of the study, they actually were doing that in sort of as they were going, as opposed to waiting to the end. The other part about the emergency authorization is they put the vaccines to the front of the list. So there's a whole bunch of drugs, other devices that Health Canada has to approve. Those all had to wait because everybody recognized that this COVID pandemic was a real problem. And so this issue of emergent experimentation or emergency use authorization is really one of what happened was the approval agencies prioritized approving the vaccines. They didn't fast track them in terms of cutting any corners. They still followed all of the rules and regulations. And these people are detail oriented. So all of the vaccines that have been approved have gotten, their due diligence. I can tell you that. And, the folks at Health Canada have presented this and have been very transparent about the rigor with which they took to approve these vaccines. But what made it faster was that all of these typical bottlenecks were much quicker. They didn't take quite as long. And it's important to know that back in November, October, there were lots of candidates. There were lots of companies that had vaccines that we thought might be successful. They didn't all pan out. And so what we've seen is we've seen the cream of the crop. The ones that actually got approved were the ones that actually were the best and really did work, because there's dozens of others that didn't hit the market because the trials didn't pan out. And that's science. I mean, we don't typically know all the drugs that didn't make it to market. In the case of COVID vaccines, we actually do. And we know that the ones that made it are really, really good and got approved relatively quickly for some of those reasons. And so it's important to know that they're still very safe. And it's not that people cut corners, but in fact that these vaccines were worked on very heavily by lots and lots of people. And, the greatest minds all got together to work on this really quickly. And that's why it happened so fast.
Awesome. Dr. Heendeniya, back to you for a sec for Ivermectin. So people were asking, can you treat COVID-19 with Ivermectin? What is that? Can you speak to that for a sec?
Yeah. So Ivermectin, this is what we call repurposed drug. Whenever there's a new infection, new disease out there, we try to use cheap drugs that we have access to. We see how it works. So Ivermectin, hydroxychloroquine, and then colchicine were the three big ones for COVID-19. Unfortunately, from the data we have so far, there's no real effect on COVID-19. The trials are ongoing. So of course, we are keeping our ears down to the ground and waiting for those results. We would love to use Ivermectin. It's cheap, it's freely available, it's not really, but cheaply available around the world, easy to get. But we do have to be careful giving out drugs to a lot of patients with COVID-19 because Ivermectin does have side effects and we don't want to end up causing any harm in the future. But if I had to guess, if Ivermectin is going to work, given it's an anti-parasitic, it probably will not work against a viral infection like COVID-19.
Dr. Osler, and this will go to everyone, Dr. Osler, are you being paid at all to promote, to push the vaccine? Or if you wanted to speak out in some way against vaccines, are you being silenced at all, Dr. Osler?
Good question. And I can see where that question comes from. People have heard over the years about doctors being paid to do this and that. I am not paid for any of the speaking out that I do. I have no relationships with any pharma companies to disclose, so I'm not on any salary list. I'm not being muzzled. I have an appointment with our university, and they support, their physicians speaking out and academic freedom. So not being muzzled, not being paid.
Dr. Potter, same to you.
I would echo everything that Dr. Osler said. I am not being paid and I am not being muzzled. And I appreciate the freedom that my university appointment gives me in that respect.
Dr. Singer, same.
So I agree with Jen. I think I appreciate the freedom that I have as an academic to sort of be protected and be able to speak out. I'm not getting paid, although I do think Doctors Manitoba is providing us a t-shirt. But I think the reason why all of us are doing this, oh yeah, you've got it on. I think the reason why all of us are doing this is because we feel it's so important. It's important for our patients, it's important for our families, it's important for, the community at large. So, I'm not being paid for this speaking engagement. I'm not getting paid by any of the drug companies or any of the companies or anyone else that's producing the vaccine. But I'm doing this because I think it's really important. And I think by us sort of, standing up as physicians and saying what we know from the training we've had, I think is an important part of, reassuring people that we've looked at this carefully and we really do genuinely believe this. It's not that someone's paying me to say this.
Dr. Heendeniya, same to you.
Yeah, same as Dr. Singer and everybody else. I mean, I did get a t-shirt. Other than that, there's no money involved here. And I'm happy to volunteer my time to educate anybody that have questions and good questions. And again, even though I'm in infectious diseases, I'm not paid by any big pharmas. I'm not involved in any of the vaccine trials.
Dr. Poliquin.
Thanks. I'm still waiting for my t-shirt. Hopefully it'll arrive soon. But same as all the other panelists, I am an academic physician. We have the privilege of academic freedom. While I have done some consultation work with pharmaceuticals in the past, this is not influencing my presence here today. I'm certainly not being paid for this engagement. My purpose for being here is to make sure that pregnant and expectant and breastfeeding patients have fact upon which to make their decisions instead of fiction.
And finally, Dr. Kalicinsky.
You're muted, Chrystyna.
Yes, there I am. I'm here on a volunteer basis, not being paid, and have the privilege of being able to speak as I want, not being muzzled. Also, being part of the university that advocates freedom for us to speak the way we wish.
Appreciate it. This is a very specific question. I hope I have this correct. I think I want to address Dr. Poliquin on this one. I might have written that incorrectly, and I apologize to the panel here. But we received a question. It's very specific and it's a very sensitive issue. And it reads, I'll read it verbatim. I have both ethical and faith-based concerns about the injection of a product that has been developed using fetal cell lines. Is this true? And if so, why is this ethical? Sorry, that was Dr. Potter. That was Dr. Potter, I'm pretty sure.
Yeah, sure. Thanks. It's an important question, and it's something that a lot of people do think about. I love vaccine questions. So a couple of things to be aware of. One is the mRNA vaccines. So the Pfizer and the Moderna vaccines do not involve fetal cell lines in any part of the production process. So that's really not an issue for those vaccines at all. For the other vaccines, the Johnson & Johnson vaccine and the Astrazeneca vaccines, where that is a very small part of it, it's important to know that there's no actual fetal material that is in the final vaccine product. And for many of the faith-based groups that have commented on this, they've looked at the morality, they've looked at all the issues, the pros and the cons, and how the process worked and where it came from, and all of that, and they have almost universally ruled that the pros of the vaccination make it more moral to get the vaccine than to avoid it when you don't have an option.
What about getting your vaccine? Some people would feel more comfortable. Can they get it from their family physician?
I would love to say yes, and sometimes you can. It really kind of depends on the supply that your physician's office has at any given time. It is certainly reasonable to call your doctor's office and ask, but they may or may not have it available when you call. In that case, it's still very, very reasonable to talk to your doctor about, is this the right decision for me? Is this something that I need to, be aware of, something particularly related to my personal health? And then they can guide you and also help you figure out where to get the vaccine, even if they can't do it themselves.
So sort of staying with that, like, should someone go for like a checkup before they go get their vaccine?
It's not routinely needed, but certainly if you have health conditions that you're concerned about, or you have questions about the vaccine and how it relates to you personally, it's very reasonable to talk to your doctor about that.
I don't know if this is a simple like supply answer, but why can't people choose what vaccine they get?
Well, you pretty much nailed it. It is mostly a supply issue and what's available at a given time. Because this is a worldwide rollout, everybody is trying to get these vaccines around the world. The manufacturers are trying to get them out as quickly as they can. And sometimes it's just an issue of what do we have at this particular moment.
And then people still have concerns. I remember when it was first announced and people sort of were taken aback because this was something they hadn't heard of before. But why can children 12 to 17, like, how are they allowed to make their own decision on this vaccine?
Well, that's a really great question. And it's not just actually unique to vaccines. It's actually for medical care in general. It generally applies. So really, if people are competent to make their own decisions, they're allowed to do that. And what competent means is that if somebody can understand what their options are, if somebody can understand the pros and cons of each option, and they really can understand what they're getting into, they have the right to make the decision for themselves. And that's sort of the reason that kids who, if they go and they see their care provider and their care provider sort of talks them through it, and they demonstrate that they understand what they're signing up for, then it's reasonable for them to make their own decision.
How can someone, actually, I'm going to, well, Dr. Osler, more than one person has asked, so I shouldn't brush past it, but how can someone get a second dose of AZ AstraZeneca?
Thanks. And that's a good question, Ace. And I think Dr. Potter touched on it a little bit right now. It is a bit of a supply issue. So the supply of the AstraZeneca vaccine in Manitoba is limited and is currently being used for second doses for people who got AstraZeneca as a first dose who can't get an mRNA vaccine as their second dose for specific reasons. And so to find the clinics with AstraZeneca doses, two options that I'd suggest. One is to go to the government vaccine website. They've got a vaccine finder section, or to check out the Doctors Manitoba site, which is manitobavaccine.ca. And both sites are updated routinely and regularly, but supply is limited right now, although I do believe there should be some more coming in the next few weeks.
Dr. H, we have a bunch of questions for you. So the topic in general is the mixing and matchings of vaccines, and sort of people hearing different things and them changing their mind about, what, my friend got this, should I get this? They're worried about Pfizer. So I'm AstraZeneca, Moderna, but people have concerns. I'm good with where I'm at. People have concerns about the mixing and matching, and what would you say to them?
Yeah, hot topic. I mean, just like Dr. Singer said, the public is along the ride with us. We, from the beginning of the pandemic, we are seeing science evolving. So the short answer is completely fine to mix and match as long as the immune response is the same. So I'll explain that a bit. This is not something new in the vaccine world. This is the first time, though, that we are paying attention to brand names. It's not like we never talked about different brand names of hepatitis B vaccines, but anybody that got the hepatitis vaccine, the series with the 2 or 3 doses, is very likely you got more than one brand name given to you over that series, but none of us were paying attention to those brand names, because at the end of the day, what matters is your body gives you the same immune response. So we know all the approved vaccines in Canada, and let's even just talk about the RNA vaccines, they use the exact same mechanism. introducing the RNA to produce a protein in your body called the spike protein, like protein from the virus. But you understand this is not a protein coming from the virus. Your body is producing the protein using the signals that we gave. And you get another different brand name of the mRNA vaccine. You're still getting the same spike protein mRNA. So you're getting the same immune response. So at the end of the day, you're going to have the exact same immune response. Interestingly, people that did receive the AstraZeneca dose followed by a Pfizer dose, they actually had a better immune response compared to the people that got 2 doses of AstraZeneca. And I'm going to assume, and I think it's a good educated guess, people that get AstraZeneca followed by a Moderna vaccine will probably have the same potentiated effect. So this is going to be, it'll become more clear science-based as the days go on. And the other thing that's important to note, a lot of people had concerns about, will I be counted as a fully vaccinated individual?
Yes, that's huge. Yeah.
Right. Yeah. So in the US, I mean, that's been the most notorious neighbor for weird rules for pandemic traveling. Finally, they have added a little fine print in their document. Anybody with WHO and FDA approved vaccination are counted as a fully vaccinated individual, even with the mix and match. And this came up a lot with the recent Bruce Springsteen concert. You can go to the concert. I don't know if it happened already, even if you're mixed and matched.
So if you're AstraZeneca and Moderna, you are considered fully vaccinated.
That's correct.
Awesome.
And Pfizer either.
Yeah, yeah. Dr. Poliquin, people had concerns about pregnant women being given early access to second doses. And there were a couple of different examples, but do you have thoughts on that or a statement on that?
It's a great question because pregnant women in Manitoba were among the prioritization group for the first dose. And there was not such a prioritization for any high-risk groups for second doses. It went based on time of first dose administration. The reason for that is because your protection comes from 2 things. 1, your own protection that you get from your own vaccines, and number 2, how much COVID is in the environment around you and how much we can protect you through herd immunity. And so prioritization for high-risk groups, including pregnant women, for first dose was definitely there. And then the priority became, we need to get as many first doses out as possible so that we can have good herd immunity. And so that's what we saw. And fortunately, as of today, if you got your first dose May the 31st, which is about the 21-day window, you can sign up for your second dose. And so that is a question that came from a supply problem, but it looks like with our improved supplies, nobody's going to have to be waiting quite so long, and people can go ahead and book their second doses if their first dose was May 31st.
Thank you. And Dr. H, back to you for a moment here. This one is enormous, and the answer might vary from today through tomorrow, but people have questions about the variants specifically and the vaccine's effectiveness against the variants.
So just want to clarify, when you say variants, I'm assuming you mean variants of concern. So there's a million variants out there when there's viruses going, but we have to specifically talk about variants of concern. So the 2 most common ones being alpha and delta. So the alpha is the one that was first introduced from UK. So it depends on which variant of concern we're talking about. Looking at the mRNA vaccine and even the other viral vector vaccines, the overall effectiveness of reducing severe infections, hospitalizations, and deaths still work even with the variant. So that's the good news. You might be at a slightly higher risk of getting the infection even if you're fully vaccinated, if you get exposed to some of these variants of concern. But remember, with the vaccine, we are trying to achieve 3 things. One thing, we are trying to reduce the risk of infection. And if you do get infected, we want to reduce the risk of you getting symptomatic. And if you do get symptomatic, we want to reduce the risk of you having to go to a hospital and then ultimately having a bad outcome such as death. So those outcomes, those important outcomes, seem still doing pretty good. What we don't know is what the Delta variant is going to do. So far, UK has been our biggest data point for Delta variant. If looking at their curves, even with the spike in the Delta variant infection in the pretty well immunized AstraZeneca heavy population, the number of the hospitalization has increased a bit, but the number of deaths continue to climb down, not climb down, to decrease. So we have not seen an increasing in death even with the Delta variant rise in the AstraZeneca vaccinated population. So I'm going to assume with the countries like Canada, where there's a lot of mRNA uptake, we won't see a big issue with the variants. And this also brings to another point I want to make. This is another reason we need to get the vaccination so we don't keep breeding variants. Because we do have variants in Manitoba. Luckily, none of them are variants of concern, but it's a matter of time. So that's why the more vaccines we get out, there's a less risk of developing variants.
You still spread the virus if you are vaccinated?
So initially, when the vaccine came out, there's all this hypotheses and theories came out saying it does not sterilize your throat area, so you can still give the vaccine. And that was a real concern we had. And that's one of the reasons we had the mask mandate on. We have the mask mandate on when you have the vaccine. But from what we can see, people that are vaccinated are not involved in the spread of infection, at least from the data we have so far. And one of the greatest places to see that is our elderly population, the elderly home. We have not seen any big outbreaks since the third wave started because they're largely vaccinated. So I think the risk of you giving it to somebody else if you're vaccinated overall is low, but we haven't proved it. The issue is, as we spoke, if you're an immunocompromised patient who gets vaccinated, I can't guarantee you'll have the same amount of response. So you might have a higher risk of giving it to somebody else. Again, that also highlights the importance of most of us getting the vaccine, because if you are vaccinated, even if you get the infection, the risk of you giving it to somebody else in your household is extremely low if everybody else in the household is vaccinated. So that's where it all comes together.
Gone into overtime a bit here. If you didn't hear the subject or the question that you wanted addressed tonight, where Doctors Manitoba does an incredible job. There's another town hall tomorrow as well, by the way, and manitobavaccine.ca. If you missed something or you want to go back, there's a lot of questions answered on manitobavaccine.ca. That's run by Doctors Manitoba. It's independent of the government COVID-19 site. Final sort of segment we'll give to Dr. Singer, and that would be sort of, let's say I'm double vaxxed. How long is that going to last? Am I going to have to get boosters? When will I know that? So it's big.
So really interesting question. It's the same kind of question that scientists and researchers are asking as we speak. I think we're going to be able to answer this question more definitively in the coming months and years. And we're going to probably know what the answer to this question is in two ways. One is studies are going to be I'm sure are already underway. And the kind of things people are going to look at is, can you still detect antibodies in people 6 months, 1 year, 2 years out? So that's one way to understand. The other will be, do we start to see people coming back into the hospital? You know, when things improve, when we get the vaccine numbers up high enough and we see that the case counts really drop, which is starting to happen already, thankfully. If that changes, if all of a sudden the ICUs fill up again, people start dying, we start seeing a huge issue, and it's happening in people who are vaccinated, we'll start to know, oh gosh, maybe we need a booster, or maybe the vaccines need to be improved in some way. But I think we'll have some signals before that. The simple answer to this question is we just don't know, but it's a fantastic question because it's exactly the kind of question that the people who research this kind of thing are asking as we speak. And we're going to watch this play out. Like I said before, this is going to be real-time science. We're going to see this evolve and it will change. And it's not changing because people are changing their mind. It's going to change because we're going to follow the data, and this will be proven, and we'll figure this answer out. And whether we need a booster or a different kind of vaccine and when that's going to be, we'll all get to find out together. You, me, and the rest of the world. So stay tuned, and hopefully it works for a really long period of time to buy us time to come up with new solutions and be ready for the next time, if there is, and hopefully there won't be.
Dr. Osler, Dr. Potter, Dr. Singer, Dr. Heendeniya, and Dr. Poliquin, and Dr. Kalicinsky, thank you so much. I have a tremendous amount of respect and admiration for what you do in your day-to-day and your research and how you serve our province. And then the fact that you volunteered your time tonight. I know you're all incredibly busy, both with work and you have your personal lives, and people really appreciate you taking the time to answer their questions. And it really does help people. And people are, they're allowed to have some fears and anxiety, and they're allowed to ask these questions. And I hope that people feel free to ask those questions. And we really, really appreciate all of you jumping on tonight. Again, if you want to go back, manitobavaccine.ca, there are a lot of questions answered on there. But to all of our panel tonight, thank you so much. We have a bunch of people behind the scenes as well who do an incredible job. So thank you all for the town hall. We appreciate it. Stay safe. All the best. Take care.